Hello everyone, welcome back to the series of lectures in pulmonology. Today we'll be discussing about pleural effusion. So we all know that the pleural space is basically the space enclosed between the parietal pleura as well as the visceral pleura. So the normal amount of fluid which is present within the pleural space is less than 10 to 15 ml of fluid. So this fluid is usually an ultrafiltrate of the plasma. This fluid is basically an ultrafiltrate of the plasma and it has low proteins and very few cells. Okay, so what is the function of this fluid? The minimal amount of fluid, about 10 to 15 ml, which is present within the pleural space, ensures the smooth functioning of the lungs during respiration. Okay, so this is about the normal pleural fluid. The pleural fluid is basically formed by ultrafiltration of the plasma, and it can enter into the pleural space either from the visceral pleura or from the parietal pleura, and the excess amount of fluid is drained by the lymphatics away from the pleural space. So what are the mechanisms by which there can be accumulation of fluid within the pleural cavity? So this can be because of increased fluid entry. Increased fluid entry means what? There can be increased permeability of the parietal or visceral pleura. So there can be increased permeability of the parietal or visceral pleura in conditions where there is inflammation. Inflammation can be secondary to an infection or in inflammatory disorders like SLE where there is inflammation of the pleura, right? So this can increase the permeability and hence the fluid can enter via the parietal or the visceral pleura. Then there can be microvascular or venous pressures can be increased, right? So whenever the venous pressures are increased, for example in a pulmonary thromboembolism or in an SVC obstruction which we see in malignancies. So in a pulmonary thromboembolism or in an SVC obstruction where we see in malignancies, there can be increased venous pressures and hence this results in an increased hydrostatic pressure and more amount of fluids get shifted into the pleural space. Right? Or there can be a decrease within the pleural cavity itself. That means what? There is atelectasis of the lungs. Atelectasis means what? There is collapse of the alveoli. So whenever there is a collapse of the alveoli, pressure within the pleural space drops, and we know that the fluid flows from the high pressure to a low pressure and hence it becomes a transudative effusion and it gets pushed into the pleural space where the pressures are low. There can be a decrease in the oncotic pressures. So when there is a decrease in the oncotic pressures for conditions like hypoalbuminemia, so there is a loss of proteins in conditions where like nephrotic syndrome. So we know from the Starling's law that the proteins are responsible for maintaining the oncotic pressure. So when the oncotic pressure falls, the fluids moves from the high pressure to the low pressure area and hence it gets accumulated in the pleural space. Okay, so this is the first mechanism or the sub mechanisms through which there is an increased fluid within the pleural cavity. So because of increased permeability due to infection or inflammation, there can be increased venous pressures in pulmonary thromboembolism or SVC obstruction. There can be atelectasis which results in decrease in the pleural pressure, and decrease in oncotic pressures like nephrotic syndrome can result in accumulation of fluid in the pleural cavity. Then it can be due to decrease in the fluid exit. We know that normally the pleural fluid is removed via the lymphatics. So if the lymphatics are blocked or fibrosed, then there cannot be any normal fluid exit and hence the fluid begins to accumulate within the pleural cavity. So this again can be due to inflammation, it can be due to infiltrative processes, most commonly due to malignancies. Okay, so malignant cells can infiltrate and block the lymphatics, right? Then hypothyroidism or injury to the pleura such as chest radiotherapy which you receive during a thyroid cancer or breast cancer, this can all cause fibrosis of the lymphatics. So there is fibrosis of the lymphatics and there can be obstruction to the lymphatic flow and hence accumulation of fluid within the pleural cavity. Apart from this, the third most important mechanism that we should know is your extrinsic causes, right? So any form of diaphragmatic or lung injury can cause accumulation of fluid within the pleural cavity. Then it can be due to atelectasis or compression. So these are some of the extrinsic causes by which fluid accumulates within the pleura. So these are the broad mechanisms by which there is fluid accumulation in the pleural cavity. So how do you approach a case of pleural effusion? This may be given as your clinical case in the final exam. So how do you approach? So history. So the first complaint that they present with is the presence of chest pain. So what type of chest pain will they have? They will have a pleuritic type of chest pain. So how do you describe a pleuritic type of chest pain? This is a sharp stabbing pain which is lateralized to one side, and it increases with coughing or deep inspiration. Okay, so this is a very important description which is called as the pleuritic type of chest pain. So pleuritic chest pain is a sharp stabbing pain which is lateralized to one side of the lung, and it increases during cough or deep inspiration. Okay, so this pleuritic type of chest pain is usually present during the initial phases of the pleural effusion. And why is this happening? This is because the inflamed pleura rub against each other. Okay, so when the inflamed pleura rub against each other, you can have a pleuritic type of chest pain. But in the later stages, once the fluid accumulates, then the pleura gets separated by the fluid between them. They do not rub against each other, and hence the pleuritic chest pain abates. So pleuritic chest pain is present during the initial phases of a pleural pathology. Second, you can have cough. So what are the characteristic features of the cough in a pleural effusion? Most often it is dry cough. And this cough shows the presence of positional variations. Okay, so there is a dry cough and it shows positional variation. Third, as the pleural effusion accumulates, they can have breathlessness. So they can have breathlessness on exertion, and if the pleural effusion is massive, it can be present at rest as well. Okay, fine. Okay, then we have to look into the comorbidities with which the patient is presenting, because many of the comorbid conditions can also result in pleural effusions. So what are the comorbid conditions that you want to ask about in the history? You want to ask about heart failure. You want to ask about chronic kidney disease, because all of them can result in fluid accumulation and anasarca in multiple organs of the body, including the pleural space. Then history of pancreatitis, because pancreatitis in itself can cause left-sided pleural effusions. Then history of CLD, because there can be channels which are created through the diaphragm from the liver to the pleural space. There can be communicating channels, and hence in CLD patients you can develop a type of effusion which is called as hepatic hydrothorax. Okay, so these are about the various other comorbidities that you want to ask for. Then you have to screen for risk factors for tuberculosis and malignancy. So what will you ask for this? You will ask for history of prolonged fevers, history of cough with expectoration, history of TB contacts especially at home, history of weight loss, right? So this is all about risk factors for TB. For malignancy, before we ask about the specific questions, we should be aware of what type of malignancies commonly affect your lung. Okay, so most of the time the pleural effusions are due to metastatic malignancies. Most of the time the pleural effusions are due to metastasis, right? So which are the malignancies which commonly metastasize to the pleura? It is your breast CA, lung CA, then lymphomas, and thyroid cancers. Okay, so you should be screening for all of these cancers whenever you see a patient of pleural effusion. Alright, then you have to also ask about the different occupational exposures, what type of occupation that they are in. Why? Because you have heard of BAPE, which is benign asbestos-related pleural effusion. So chronic asbestosis can also be associated with pleural effusions. Then you'll have to screen for other systemic conditions, especially your autoimmune disorders like your SLE, then hypothyroidism. So these are some of the other conditions, including rheumatoid arthritis, which can result in cholesterol pleural effusion. So these are the other systemic conditions which can result in pleural effusions. So for SLE, you will have to ask about prolonged fevers, you'll have to ask about weight loss, then you ask about in your examination and laboratory investigations, you may find evidence of cytopenias, or you may find evidence of proteinuria. They may have history of joint pains, alopecia, and skin rash, especially your butterfly skin rash, which is characteristic features of lupus. When you ask about rheumatoid arthritis, long-standing pains, and on examination you might find joint deformities as well. Okay, so that is about the various systemic symptoms that you have to screen for. Then you will have to ask about different procedures that the patient may have undergone. Okay, so the procedural related pleural effusions are categorized into a different group that we call as PEEVO. So what does PEEVO stand for? It stands for pleural effusion of extravascular origin. Okay, it stands for pleural effusion of extravascular origin. So what do you mean by that? This basically refers to the effusions that arise due to certain procedures. For example, you have your urinothorax. So for example, you have your urinothorax. Then in certain conditions where you do a transurethral resection of prostate, for example in your BPH, here you give large amounts of IV fluids during your TURP procedure, which is rich in glycine. So this results in a glycinothorax. So in a urinothorax, there is a fistula which is created between the lung and the bladder. The glycinothorax, it is because of IV hydration to a very large extent during your TURP procedure. Then whenever you place a CSF shunt, you place this ventriculoperitoneal shunts. These shunts are placed, for example, in cases like hydrocephalus in order to bring down your pressures, right? So whenever you place your CSF shunts or your VP shunts, the CSF can also, when the shunt migrates by chance, the CSF can also leak into the pleural space, and this is another example of a PEEVO, right? Then another procedure where you can have fluid accumulation within the pleural cavity is a patient who has been on long-term peritoneal dialysis, where the peritoneal dialysis fluid can migrate into the pleural cavity. So always be aware of these kind of procedures which can result in pleural effusions. Last but not the least, very importantly, you will have to screen for the different drugs which can be associated with pleural effusions, for example, amiodarone and certain cancer chemotherapeutic drugs like bleomycin. Then you would have heard of this SHIP group of drugs which are associated with drug-induced lupus, right? So this includes your sulfa drugs, INH, hydralazine and procainamide. So these group of drugs which are associated with drug-induced lupus can also result in pleural effusions. Okay, so this is about the extensive history and extensive etiologies that you should be aware of whenever you are examining a patient with pleural effusion, of which very importantly, you have to remember pleuritic type of chest pain, dry cough with positional variation, and always remember to ask about comorbids, and always screen for tuberculosis and malignancies. The other causes are less common causes for pleural effusion. Fine? Then, on examination, what all will you find in a patient with pleural effusion? So we have done your history. So you've localized that this is a pleural pathology. So what all will you find on your examination? So on the examination, you will find that there can be a localized fullness of the chest. So if this is a right-sided pleural effusion, when you just inspect the patient, you might find that there is fullness or bulges which are present on that particular side. Then the movements of the chest will be decreased on that side. There is decreased movement of the chest. Okay. So when you do your measurements, of the hemithorax diameter will be increased because of the accumulation of fluid. There is a decreased movement on that side and there is an increase in your hemithorax diameter. Okay. Then on your percussion, what will you find? On percussion, you will find a dull note. Okay, depending upon the amount of effusion, you might find different note. Most often it is a stony dullness. Okay, fine. Then on auscultation, what will you find? On auscultation, you will find that there are decreased breath sounds as compared to the other side, or even absent breath sounds. Just above the level of pleural effusion. So if this is your effusion, just above the level, there will be a part of the lung which usually gets consolidated because of the excess amount of effusion, and hence it behaves like a consolidated area just above the level of effusion. And here if you auscultate, you will find evidence of consolidation like egophony and bronchial breath sounds. Alright, fine. So this is about the different examination findings that you will find in a patient with pleural effusion. Also, another thing that we had to mention is about the trachea, right? So the trachea will be shifted to the opposite side, right? So if this is the trachea, if there is a massive pleural effusion, then this is going to shift the mediastinum to the opposite side. So the trachea gets shifted to the opposite side. So what are the conditions where you have a pleural effusion on one side but the trachea remains center? So this happens when the pleural effusion is associated with an ipsilateral fibrosis or a ipsilateral collapse, right? So if there is a pleural effusion and there is a mass here, then the lung is going to collapse, right? So this is going to have a pleural effusion and there is an endobronchial mass, then the lung is going to collapse on that side and you will have an effusion, but the trachea will not be shifted. Okay. So this is about the various examination findings, and of course in your general physical examination, you will have to look for the presence of lymph nodes, you will have to look for evidence of any breast or thyroid malignancies, you will have to look for evidence of clubbing. Okay. And if you are looking at certain systemic examination findings, evidence of RA, evidence of malar rash, etc. will help you finding the etiology. Okay. So this is about your examination. Now let us look at the various causes for pleural effusions. So pleural effusions can be classified as transudative and exudative based on a particular criteria that we call as the Leitz criteria. Okay. So we will first list the causes for your exudative and transudative effusions, then we will look at the Leitz criteria. So under the transudative effusions, the causes can be because of congestive heart failure, chronic liver disease, chronic kidney disease and mixed edema. Exudative causes include infections, neoplasms and PTE. GI causes, which can include a perforation of the esophagus, pancreatitis. Pancreatitis predominantly causes left-sided pleural effusion. Then we have connective tissue disorders like SLE, RA, certain forms of vasculitis, sarcoidosis, then uremia. Then we have something called as Meigs syndrome. Meigs syndrome is basically an effusion that arises secondary to ovarian tumors. Then remember, drugs that cause effusions include nitrofurantoin, bromocriptine, amiodarone and dasatinib. Then radiation induced and injuries like your thorax or pneumothorax during an RTA can be associated with effusions. Okay, so that is about the different causes. Now let us understand the approach to the diagnosis of a pleural effusion. Now you have done a history, you have done a physical examination, and you have found that the patient is having pleural effusion, right? So the first step would be you try and obtain a thoracentesis. What do you mean by thoracentesis? You put in a needle into the pleural space and you draw the fluid and send it for examination, right? So this is a thoracentesis or a pleural tap. Alright, so how is the pleural tap done? So usually in the current era, we basically do it a ultrasound-guided procedure. Okay, the pleural tap is usually done as an ultrasound-guided procedure in the current era, but previously we used to do it as a blind procedure as well, right? So the pleural fluid is usually taken from the posterior axillary or in your posterior region around the 5th, 6th intercostal space, right? So you start percussing from above up to the point where the dullness is heard, and that is where you localize the pleural fluid and you take a needle, attach it to a 3-way catheter and then attach it to a bottle where if you are draining out the fluid or if you are just taking a sample, you attach it to the syringe and try and withdraw the fluid. Okay, so you go in using a needle into the pleural space, right, and then you try and draw the sample. But before we go ahead and do a procedure, whether it is diagnostic or therapeutic, always remember that there can be certain contraindications. So what are the contraindications for a pleural tap? Only if there are certain rib deformities. If there are certain rib deformities, that is a contraindication for a pleural tap. Also, if the patient is having a bleeding diastasis or the platelet counts are less than 50,000, then there can be a high chance of bleeding into the pleural cavity and hence this is contraindicated. Okay, and always remember from your basic anatomy that the vasculature, if these are the ribs, the vasculature in the ribs are usually present in the lower border of upper rib, right? So they are present in the lower border of upper rib, the vasculature is present, and hence if you want to introduce a needle and enter the pleural space between two ribs, always go along the upper border of lower ribs. Okay, so you always go along the upper border of lower ribs to ensure that you do not hit any of the vessels and cause bleeding, right? Certain other precautions that you have to take in, especially if you are using a 3-way cannula. So the 3-way usually has a cannula or a cork stop like this, right? The place where there is no cork stop basically means that the fluid will not flow, right? So if you are putting a needle this way and the syringe is here, right? So you want to aspirate the fluid. Now you place your 3-way directed this way, right? So your 3-way is directed this way, which means what? There will be fluid which will be flowing this way, right? Also there will be fluid which is going down this side. Okay, so here you can attach your bottle and collect your fluid, and here you can take the fluid for your diagnostic purposes, and here the fluid will not flow because there is no direction to flow that way. But be very, very careful when you are aspirating it. Ensure that you do not push back the syringe because there can be some amount of air which is present in the syringe, and if you push it back this way, then the air is going to go and get accumulated within the pleura and you are going to cause a pneumothorax, right? You're going to cause a pneumothorax because you will find air in the pleural cavity. Also be very, very careful that whenever you are puncturing the pleura, you can inadvertently go and puncture the lung itself and hence again resulting in a pneumothorax. So that is a very, very important precaution that we have to take, and that is the reason why nowadays the pleural fluid analysis is being done as a USD guided procedure. Okay, fine. So this is about the steps that you have to take, the precautions that you have to take when you do a pleural fluid analysis. Now once you have obtained a pleural fluid analysis, what are the samples that you want to send? Okay, so what are the samples that you want to send when you obtain a pleural fluid analysis? So you will send for a routine which includes the total counts and the differential counts. Then you will have to send for a pleural fluid protein. You will have to send for a pleural fluid LDH. Okay, and if you are suspecting an infection within the pleural cavity, you may have to send for a pleural fluid gram stain and a pleural fluid culture. And in tuberculosis, if you are suspecting, then you may have to send for a pleural fluid adenosine deaminase levels and a pleural fluid AFB. Okay, so this is about the various tests you would routinely do when you take a pleural fluid analysis. If you are suspecting a malignancy, then you may also have to send for a pleural fluid cytology. Okay, so this is about your pleural fluid analysis. So the first thing that you would like to do is, using an ultrasound, get a pleural fluid and check for your these things, pleural fluid count, protein, LDH, and this will help you in identifying the likely etiology of the pleural effusion. Okay, fine. So now that you have done that, let us understand how will you approach a case of pleural effusion. So the first step whenever you see a pleural effusion is that you perform a diagnostic thoracentesis, measure the pleural fluid protein, LDH and counts, and this biochemical analysis that we get is the basis of what we call as the Leitz criteria. Okay, so what is the basic use of the Leitz criteria? The Leitz criteria is basically used to differentiate between pleural effusions, whether they are exudative or transudative, because if it is a transudative effusion, then treatment of the underlying cause will most often suffice, right? If it is because of a heart failure, you bring the heart failure into control. If it is because of CKD, you dialyze them. But if it is a transudative effusion, then you have to hunt for the cause. So what are the parts of the Leitz criteria? So we take the pleural fluid by serum protein more than 5. Okay, that is the first point. Second point is pleural fluid by serum LDH more than 0.6. Pleural fluid by serum protein more than 0.5. Pleural fluid by serum LDH more than 0.6. And pleural fluid LDH is more than 2/3 the upper limit of normal of the serum LDH. So these are the 3 points. If even one of it is present, then it is Leitz criteria positive, and this means that the effusion is exudative in nature. Okay, so this is your Leitz criteria. Pleural fluid by serum protein more than 0.5, or pleural fluid by serum LDH more than 0.6, or pleural fluid LDH more than 2/3 the upper limit of normal of the serum LDH. So if any of these criteria are positive, then this is an exudative pleural effusion. Okay, now if this is an exudative pleural effusion, then you will have to look for the glucose, the cytology, the total counts, the differential counts, culture, gram stain and other markers for TB to find out the etiology of the pleural effusion. Okay, a very important point that we have to consider is what are the conditions where the pleural fluid glucose is less than 60 milligrams per deciliter. What you have to remember is malignancy, severe bacterial infections and rheumatoid pleurisy. These are 3 conditions where the pleural fluid glucose is less than 60. Okay, fine. Also, you will have to consider other conditions such as your pulmonary thromboembolism or even a pulmonary TB. Okay, so this is the overall approach to a pleural effusion. Fine. Now, what are the shortcomings of this Leitz criteria? So, what are the shortcomings of Leitz criteria? The major problem which people found with this Leitz criteria is that it misidentifies 25% of the transudative effusions as exudative effusions. Okay, so it misclassifies the transudates as exudates, and we will end up going on searching for further etiologies. That is the reason why they have come up with this new ratio, which is called as the pleural fluid serum protein gradient. Similar to how we have the serum ascites albumin gradient or the SAG, we have the pleural fluid serum protein gradient. If it is more than 3.1, then this is a transudative effusion. Okay, so this is a transudative effusion. So what is this? This is the pleural fluid serum protein gradient. So this is the role of your pleural fluid serum protein gradient in identifying which exactly is a transudative effusion. Okay, so now let us look at some of the most important etiologies for pleural effusion one by one. So in an uncomplicated parapneumonic effusion, so you have a pneumonia and you have a parapneumonic effusion, right? So when do you call it uncomplicated? So uncomplicated is when the pleural fluid is serosanguinous in nature, the glucose levels are more than 60, it is predominantly neutrophilic in nature, and the pH is more than 7.2. So this is about the pleural fluid characteristics of an uncomplicated parapneumonic effusion. But in certain conditions, the pneumonia can undergo complications and the pleural effusion along with that can become loculated, or there can be development of frank pus within the pleural cavity, and this is what we call as the empyema, right? So a pneumonia patient who is continuing to having fever and there is no improvement, you do a repeat X-ray and there is worsening of the pleural effusion, then this is when you consider a complicated parapneumonic effusion. And what are the pleural fluid characteristics of a complicated parapneumonic effusion? Remember, glucose less than 40, LDH more than 1000, pH less than 7.1, very, very important. And you can have frank pus in the cavity, you can have frank pus in the pleural fluid aspirate, or you can find gram stain positive or culture positive. Then any of this is an indication for ICD placement. Okay, so this is a complicated parapneumonic effusion and this is an indication for your ICD placement. An ICD or a pigtail placement where you put a drain into the pleural cavity and you drain out the fluid. Alright, so that is about your parapneumonic effusions. Then, how will you identify a tubercular effusion based on your pleural fluid analysis? Again, this has a low glucose because the tubercular bacteria is going to consume the glucose for its metabolism. The pH is less than 7.4 and we have ADA levels more than 40, right? Most often it may not be very specific. This can be seen in malignant effusions as well, but here it is predominantly ADA more than 40 and it is a lymphocytic effusion, unlike your bacterial or your pneumonic or parapneumonic effusions where there are neutrophilic in nature. So this is a predominantly lymphocytic effusion in your tubercular effusions. And most of the time, will you find AFB or not? AFB positivity or pleural fluid gene expert positivity is very, very rare in your tubercular effusions because they are due to a hypersensitivity reaction. They are not due to actual seeding of bacilli into the pleural cavity. They are due to hypersensitivity reactions and hence presence of AFB or gene expert positivity is quite rare. Okay, then the next type of effusion is a chylothorax where there can be damage to the lymphatic ducts due to radiotherapy or due to trauma, or it can be due to inborn disorders where there can be tracts between the pleura and the lymphatic system and you can develop a chylothorax. So there is chyle in the pleural cavity and this is characterized by a lymphocytic effusion with elevated triglycerides more than 110. So that is how you identify a chylothorax. Then cholesterol effusions. What are cholesterol effusions? They are more commonly found in TB as well as rheumatoid arthritis. Okay, so cholesterol effusions are more commonly found in TB as well as rheumatoid arthritis. It is characterized by pleural fluid cholesterol levels more than 200 mg per deciliter, cholesterol by triglyceride ratio more than 1 and absent chylomicrons. So that is your cholesterol effusions. Then malignant pleural effusions, right? So 75% is due to lung, breast or lymphoma and primary pleural malignancies include mesotheliomas. Okay, so here you will find pleural fluid cytology and again here the effusions are usually lymphocytic in nature. Many a times you will not be able to find out whether this is a malignant pleural effusion or not, and in these cases you will have to do a CT or UST guided biopsy of the pleural thickening. So if you do a CT, this is your cut and you will find that there is a pleural thickening. So you can do a CT guided biopsy of the pleural thickening or an ultrasound guided biopsy of the pleural thickening. Then similar to bronchoscopy, we have another procedure which is called as thoracoscopy where you attach a camera and look into the pleural space, right? So thoracoscopy, the advantage is that you can find direct biopsies from the lesion itself and you can also visualize the lesion. So this is the other method by which you can diagnose malignancies. Okay, so this is about your malignant pleural effusions. Now let us look at the management of pleural effusions. So the first step obviously would be drainage. So in mild to moderate effusions, most of the time, if it is a transudative effusion, you just have to monitor and manage the underlying cause. But in exudative effusions, you may require drainage of the fluid, especially if it is massive pleural effusion and it causes a severe breathlessness, right? So treatment of the underlying cause becomes very important. Where do you find recurrent pleural effusions? Recurrent pleural effusions can be seen in congestive heart failure, hepatic hydrothorax and malignant pleural effusions. Okay, now what about the management of recurrent pleural effusions? So always remember that especially malignant pleural effusions, they can recur to more than 3 to 4 times a year and the patient becomes extremely dyspneic, right? So in these patients, you may have to do a palliative process, and the palliative process would be that you may have to put in a ICD or an indwelling catheter, and this will continue to drain the fluid throughout. But they may not be able to remove the catheter because the moment you remove the indwelling catheter, the fluid may reaccumulate. So if you are considering a catheter placement for a palliative process, then you can place it. Okay. So many of the times malignant pleural effusions are difficult to manage because treatment of the underlying cause may also become very difficult, and if you are opting for palliation, then you can place an constantly indwelling pleural catheter. The other procedure that we can do is something called as pleurodesis. So pleurodesis basically means that you insert or you basically inject certain substances. Most often it is talc, which causes irritation and inflammation of the pleura, and this causes both the visceral and parietal pleura to stick to one another and it prevents the accumulation of fluid, and this is what we call as the pleurodesis, right? So this is a chemical pleurodesis. So pleurodesis can be used as a treatment option in certain conditions where you have recurrent pleural effusions. So what are those conditions? In slowly accumulating effusions, you can try pleurodesis. But the underlying important feature that you have to remember is that this can be done only in cases where there is an expandable lung. For example, if this is your pleural cavity and this is your lung, right? So there is some effusion which is there here, but your lung has undergone a collapse, and over the course of time, because of infiltration like a malignancy or due to chronic inflammation and infections like a TB or malignancy, there can be an underlying fibrosis of the lung. Now, if the lung becomes fibrosed, even if you remove the surrounding fluid, the lung cannot expand back to its normal shape, and this is what we call as a NEL or a non-expandable lung. So, if you have a non-expandable lung, is there any point of doing a pleurodesis? No, right? So, the most important underlying condition for a pleurodesis to be successful is that you should have a expandable lung. So, what are the conditions where pleurodesis has been tried? In recurrent pleural effusions due to peritoneal dialysis, nephrotic syndromes, heart failure, hepatic hydrothorax and lupus pleuritis. The final treatment for recurrent effusions can be by your CTVS surgeons, where they can do a decortication of the lung and prevent the accumulation of further fluid. Okay, clear? So this is about pleural effusions. Thank you.